Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 169 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, which statements listed below regarding the diagnosis of Clostridioides difficile infection, abbreviated as CDI, is most accurate? Is it A. Independent use of polymerase chain reaction, abbreviated as PCR testing without enzyme immunoassay, abbreviated as EIA toxin assay, is associated with overdiagnosis and increased health care costs, or B. Routine screening of all patients presenting to the emergency department with acute diarrhea is recommended for infection control, or C. After a positive EIA toxin B assay, PCR, or for toxin B is required to confirm active infection in patients without acute diarrhea, or is it D. Use of molecular testing is associated with a declining rate of detection? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Independent use of PCR testing without EIA toxin assay is associated with overdiagnosis and increased health care costs. Answer D is incorrect because the introduction of molecular testing such as PCR has significantly increased the diagnosis of CDI. Answer C is incorrect because the toxin B assay, though not as sensitive, is predictive of true infection, and confirmation is not necessarily required. Also of importance, these tests should not be done on anyone who does not have acute diarrhea. Answer B is incorrect because routine screening on all patients would only result in false positives and overdiagnosis. This has not been proven to reduce the risk of CDI. Answer A is correct, because of the sensitivity of these tests. Use of PCR without toxin assays is associated with overdiagnosis, resulting in excess treatment, reporting, and health care costs. Please transit to the next question. And the next question reads, which of the following would be the most appropriate treatment for a patient with a diagnosis of CDI, according to toxin assay and PCR, in the ICU with abdominal distension? Would it be A. Fidaxomicin 200 mg orally twice daily plus vancomycin per rectal 500 mg twice daily for 10 days, or B. Vancomycin 500 mg orally 4 times daily plus metronidazole 500 mg IV thrice daily for 2 weeks, or C. Metronidazole 500 mg orally 4 times daily for 2 weeks, or would it be D. Vancomycin 250 mg orally 4 times daily for 2 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Vancomycin 500 mg orally 4 times daily plus metronidazole 500 mg IV thrice daily for 2 weeks. Answers D and C are incorrect because combination therapy for a critically ill patient with CDI with severe abdominal distension would benefit from dual routes of delivery. Answer C is also incorrect because metronidazole should only be reserved for mild to moderate infection. Answer A is incorrect because Fidaxomicin lacks data in critically ill patients, and combination with rectal vancomycin is not supported by published evidence. Answer B is correct because oral vancomycin plus intravenous metronidazole is supported by evidence in critically ill patients. Vancomycin dosing may be up to 500 mg orally if concerns exist for adequate colon concentrations. Please advance to the next question. And the next question reads, which of the following best depicts one of the risk factors associated with recurrent CDI? Is it A. pregnancy, or B. male sex, or C. diabetes mellitus, or is it D. concomitant antibiotics? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. concomitant antibiotics. Answer C is incorrect because diabetes mellitus has not consistently been linked as a risk factor for CDI primary or recurrent infection. Answer B is incorrect. Females have shown a higher rate of infection, though it is not confirmed that female sex is specifically a risk of recurrence. Answer A is incorrect because although pregnancy may be an emerging population at risk in the community, it has not been linked to recurrence at this time. Answer D is correct. Concomitant antibiotics have been linked to higher recurrence rates, and stewardship interventions to reduce unnecessary concomitant antibiotics may be an option for targeted interventions. Proton pump inhibitor use, older age, that is older than 75 years, and severe immune compromise have all been linked with higher recurrence as well. Please advance to the next question. And the next question reads, in J.M.W., a middle-aged patient with a second recurrence in 8 months, which of the following regimens would be the most appropriate for therapy? Would it be A. Fidaxomicin 200 mg orally twice daily for 3 weeks, or B. Vancomycin 125 mg orally 4 times daily for 2 weeks, followed by a 6-week pulse dosing regimen, or C. Vancomycin 125 mg orally 4 times daily plus metronidazole 500 mg orally thrice daily for 3 weeks, or would it be D. Metronidazole 500 mg orally thrice daily for 3 weeks plus bezlotoxumab weight-based dosing times 1 dose? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Vancomycin 125 mg orally 4 times daily for 2 weeks, followed by a 6-week pulse dosing regimen. Answer D is incorrect because metronidazole is unlikely to be therapeutic in multi-recurrent patients, and extended courses may be associated with adverse events. Bezlotoxumab may be considered but was not specifically studied in this patient cohort. Answer C is incorrect because combination therapy has not been shown to be more effective at reducing recurrences or managing recurrent infection. Answer A is incorrect. Although Fidaxomicin reduces recurrence rates significantly compared with oral vancomycin, it has not been evaluated for extended courses beyond 10 days. Answer B is correct because the 2013 ACG guidelines as published in the American Journal of Gastroenterology in 2013 recommend a pulse dosing of vancomycin after an initial 2-week regimen to reduce the risk of further recurrence. Please advance to the next question. And the next question reads, given recent evidence, which of the regimens listed below would be the most appropriate alternative to surgery for young adults presenting with uncomplicated appendicitis? Would it be A. Cefoxitin 2 grams IV 4 times daily plus fluconazole 400 mg orally once daily for 5 days, or B. Co-amoxiclav 500/125 mg orally thrice daily for 5 days, or C. Ertapenem 1 gram IV once daily for 3 days, followed by 7 days of levofloxacin 500 mg orally once daily plus metronidazole 400 mg or 500 mg orally thrice daily, or would it be D. Levofloxacin 500 mg IV or orally once daily for 3 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Ertapenem 1 gram IV once daily for 3 days, followed by 7 days of levofloxacin 500 mg orally once daily plus metronidazole 400 mg or 500 mg orally thrice daily. Answer D is incorrect because anaerobic coverage would be most appropriate for appendicitis. A 3-day regimen is not evidence-based as an alternative to surgery. Answer B is incorrect. Although amoxicillin clavulanate would have a potentially appropriate spectrum, there is concern for increasing resistance and lack of data for a 5-day course as alternative to surgery. Answer A is incorrect because a 5-day course for cefoxitin has not been evaluated as an alternative to surgery, and empiric antifungal therapy is not indicated. Answer C is correct. This regimen was evaluated in the APPAC study, a randomized, controlled, non-inferiority trial. Although non-inferiority was not achieved statistically, surgery was avoided at the 1-year follow-up in over 70% of patients, and it is generally accepted that this may be a patient-specific alternative to acute surgery. It is unknown whether an alternative antibiotic to ertapenem may be used in the first 3 days of therapy. Please advance to the next question. And the next question reads, considering the 2013 American College of Gastroenterology, ACG guidelines, which of the following statements is most accurate regarding antibiotic use in acute pancreatitis, AP? Is it A. Antibiotic therapy is recommended in patients with AP and suspected infected necrosis, or B. Antibiotics are primarily indicated in those with severe AP, according to the 2013 revised Atlanta classification, or C. Ceftriaxone plus metronidazole plus fluconazole is the first-line recommendation for initial therapy in patients with AP, or is it D. Antipseudomonal beta-lactams with anaerobic coverage are recommended for prophylaxis of infection in patients presenting with AP? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Antibiotic therapy is recommended in patients with AP and suspected infected necrosis. Answer D is incorrect. According to the ACG guidelines as published in the American Journal of Gastroenterology in 2013, antibiotics are not routinely recommended for prophylaxis in AP. Answer C is incorrect because recommendations currently include an antipseudomonal agent with good penetration into the pancreas, e.g., carbapenems, or levofloxacin, and antifungal therapy empirically is not recommended. Answer B is incorrect because classification as severe AP is not an indication for antibiotic without evidence of necrosis and/or extrapancreatic site of infection. Answer A is correct because antibiotics are guideline recommended in patients with suspected infected necrosis. Please progress to the next question. And the next question reads, according to the 2010 Infectious Diseases Society of America (IDSA) guidelines, published in the Clinical Infectious Diseases Journal in 2010, which is most accurate regarding empiric management of community-acquired intra-abdominal infections, abbreviated as IAIs, is it A? Because of emerging resistance, cefoxitin is no longer recommended as a preferred therapy, or B? In patients with immunoglobulin IgE-mediated penicillin allergy and severe disease, tigecycline is preferred first-line therapy, or C. Vancomycin is not recommended for patients with mild to moderate disease, or is it D. Piperacillin, tazobactam as a single drug is recommended as first-line therapy for mild to moderate disease? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Vancomycin is not recommended for patients with mild to moderate disease. Answer D is incorrect because antipseudomonal therapy is not recommended in patients with mild to moderate disease presenting with community-onset infection. Answer B is incorrect because tigecycline is not a preferred therapy for patients with severe disease. Answer A is incorrect. Although some local resistance may be present, if known, cefoxitin is recommended as a first-line option in mild to moderate infection as a single agent. Answer C is correct because evidence suggests that adding vancomycin to empiric regimens does not improve outcomes. Please progress to the next question. And the next question reads, which recommendation for antimicrobial management of spontaneous bacterial peritonitis, abbreviated as SBP listed below, is most accurate? Is it A? Cefotaxime is the most widely studied antibiotic treatment for SBP, though ceftriaxone may be considered an equal alternative, or B? Antibiotic prophylaxis is recommended in all patients with hepatic cirrhosis and serum albumin less than 2.5 grams per deciliter, or C. Recommended first-line therapy includes a third-generation cephalosporin plus metronidazole, or is it D? If the patient previously received fluoroquinolone prophylaxis, empiric systemic antifungal therapy is recommended. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Cefotaxime is the most widely studied antibiotic treatment for SBP, though ceftriaxone may be considered an equal alternative. Answer D is incorrect because antifungal therapy isn't indicated unless fungal infection suspected after gram stain. Answer C is incorrect because third-generation cephalosporins are recommended as empiric initial therapy as a single drug. Answer B is incorrect because long-term prophylaxis is indicated in one or two scenarios: 1. A prior episode of SBP, or 2. Patients with cirrhosis and ascites with an acidic fluid protein of less than 1.5 grams per deciliter with impaired renal function or liver failure, according to the 2013 American Association for the Study of Liver Diseases Guidelines on Treating Patients with Ascites. Answer A is correct because early clinical trials for SBP primarily used cefotaxime, though experts agree that ceftriaxone may be a clinically equivalent alternative. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 170.